Hi everyone. Thanks for all coming. All right, good evening and welcome to SMAPS. My name's Emma, I'm the founder of Some My Therapy and Pilates, and thanks for all coming in tonight. For those who don't know SMAPS, we're passionate about helping bodies better understand, passionate about helping people better understand their bodies and make informed decisions about their healthcare. That's exactly why we created Feel Good Fridays. It's a free community event where we bring local professionals in and together they can share their knowledge with our community. Tonight is a perfect example of that. We are very lucky to be joined by our local podiatrist, Ed Fenwicke, not Fenwick, from Peninsula Foot Clinic. Ed graduated with a Bachelor of Podiatry in Albury and has spent the last 12 years helping the Mornington Peninsula locals stay active, move well and be better understood and better understand their bodies from the ground up. He has experience working with people of all ages and his particular interest in helping people manage complex pain conditions. When I asked Ed for some information for tonight's introduction, his response was, "I don't need a big intro. I hate hearing about myself." So in the interest of keeping him happy and getting straight down to the good stuff, please give Ed a warm welcome.
Thank you. I honestly thought there'd be like 5 people, so that's awesome. Few people I have seen, which is also fantastic. That means hopefully I've done something right along the way. So thanks everyone for coming, obviously. So I've got a little bit of a rundown. That's more to keep me on track than anything else. But we'll go through these common sort of topics or the things that I think as a broad group we're all going to get the most out of. So choosing the right shoes, a little bit of kid stuff, so common pains and injuries in kids, and then common for adults. And that's fairly brief, but I'm going to sort of dive into why that can be a bit more difficult in those, like in the nuance in those cases. Common foot myths, ones that I hate, really, really hate. Foot myths, because usually they're targeted at manipulating people into spending money, drives me mental. And then when to seek help and where to find it. And we'll go through some questions at the end. Quick note, I love questions. I love people learning, love info. So if you want, stop me at any point, ask a question. We're all here to learn. I honestly, if you leave here tonight and don't learn anything, I haven't done my job. Yeah, I really... So we'll start with common pains, common childhood injuries, growth pains and things like that. These things appear fairly commonly in active populations, so we see a lot through ages about 7 through 14 as a general age bracket. That's the time when most of the growth plates in children are actively changing, and they're the times we tend to see pain. The common ones, Severs, Osgood-Schlatters, Islands. I just want to break this down for a second. They're all called Sever's disease, Osgood-Schlatter disease. The names, Sever was the first person who wrote about it. So it's nothing to do with being severe or significant. And none of them actually meet the guidelines for disease. They should have all been reclassified as syndromes, but for some reason we still call them diseases. So a lot of your kids' growth pains sound far more significant, far more severe than they are. Doesn't mean that they're not painful, and they are, they're incredibly uncomfortable. But yeah, the wording's a little bit interesting on some of those. So we'll go through who, what, why, when. Your who, generally speaking, it's your active kids. Unfortunately, these things don't often affect kids that aren't that active. Your couch potatoes can get them. There's generally a few other reasons why. But the age bracket, again, 7 through to about 14, and it can extend out either side depending on like bone age and things like that in certain kids. Some people advance a bit quicker. All of these things are named on their location. So they're exactly the same condition in slightly different spots. So Sever's happens only at the heel. Osgood-Schlatter's happens at the knee. You can have them at any growth plate. So we see them inside of the foot, outside of the foot. I've seen some soccer injuries where they're in the growth plate for the base of the big toe because we're hitting and impacting with the inside of the foot heaps. But they really only affect that growth plate. Basically what it is, if you think about in the case of Severs, Severs will get deep pain in the heel, so a fairly deep throbbing pain after activity in the heel. It's always associated with activity as well. So if they have a few days off, they're relaxed, they're not doing much, especially if you're on like a pool holiday and things slow down a lot, there's not a lot of pain. They play sport, the end of a game, halfway through a game, or the end of a big week. It's a cumulative stuff. So it's got a very particular pattern, and understanding that pattern's also really important in understanding that when to know when these are more significant or more sinister. But the pattern is very much attached to activity. The reason is, at that age bracket, these two bones, or this bone here, calcaneus, is actually split along this line by a growth plate. There's a piece of bone here and a piece of bone here. If you think about the role of the Achilles and the calf muscle when we run, when we move, so in that scenario there, to run, to move, you are pushing down, and we're actually pulling along that line of force in order to push the foot down. When you stand on the other side of this equation, when you stand, your foot actually lengthens out. When you go try on a pair of shoes, they make you stand up because your foot gets longer. It means that walking and moving and running, we've got this pulling that way, this pulling that way all the time, and we have this constant tug of war between the two. So growing pains are, generally speaking, culmination of that repetitive load. Treating them then has nuance based on which part of the equation is more active. So some people have really tight calves, whether that's muscle tension or whether it's high tone associated with things like neurological conditions or neurodivergence and things like that. We actually see some of those children with a lot higher tone, and they don't release the calves particularly well. That can be why a lot of people focus on treating this side of the scenario. So this is where you get people go, I want to do stretches and I want to do physio and I want to do these sorts of things. If it's more this side of the scenario where it's the foot moving, that's where you start going, okay, orthotics is going to be more useful, footwear is going to be more useful, or we have combinations of. And I think it's really important to go through that. My main issue with how they're treated sometimes is that people you treat Severs this way, or you treat Osgood-Schlatters this way. They have different reasons for turning up and in different amounts. Some kids it's 50-50, some it's 100% this and nothing the foot. So you speak to somebody who's been treated for Severs and they've had orthotics and they work really well, and then the next person goes, that didn't work. They were terrible. It's absolutely true. But there's nuance in why it turns up in the first place. Understanding why it's turned up is more important to how you treat it. So especially talking to anyone at clubs and things like that, 40% of kids will have Severs at some point if they're in that active cohort. So a lot of people are getting it, and you get 1,000 different reasons, 1,000 different options on how to treat it. So it's a hard one to treat, but the first thing is to actually work out the contributing factors. The beauty of these, I think it's worth mentioning, the beauty of these is that it's really, really, really hard to do any long-term structural damage with growing pains. if they have the pattern of growing pains and we can manage symptoms, the aim is to manage symptoms so that we can still be active, we can go and do sport, and we can play. We might still pull up sore. We might still get a 1 or a 2 out of 10 at the end of a game or things like that, and that's okay through those growing years. But understanding that once that goes past 6 or 7 and it starts limiting kids' activity, it starts telling them not to engage, I don't want to go to training, I don't want to do sport, that's when we really need to intervene and start making sure that we're keeping kids active so they can enjoy the other aspects that come with sport. And I think that's, a little bit's okay, anymore's not. Has anyone got questions on?
Yeah, just those ankle straps that you see for Severs, what's your thoughts on those? The ankle brace type things that
Yeah.
hold your foot together.
Yep. And you will get some change from them. So there's one other part that I haven't put to this. So the way I try to explain it normally with patients is this is number 1, the most likely side of it to cause. This is number 2. The third is shock attenuation through the heel. So as you run an impact, you get a shock reverberate through the heel. How much more often we see severs when it hasn't rained?
Oh, okay.
Because all the ovals are really hard.
Yeah.
So
I read something about where they place the studs on the heel.
yeah,
Well,
can impact it, absolutely.
Right
But the straps can help just by holding the fat tissue under the heel properly.
Yeah.
So you'll get some relief, like gel heel pads and things like that. There's a fair few retail items that will address that part of it. They have a limitation. If that's the first port of call and it works and it's helping, absolutely. There's no harm in using some of those. But then once it gets to a certain point, relying on a retail item at that point and saying, okay, well, what's the next retail item is going to be fairly useless. Has anyone got any other questions on?
I have one more question.
Yeah.
So it doesn't do long-term damage to the growth plates at all?
It's very, very, very unlikely.
Right.
And talking more specifically about severs.
We just talked about Severs in the couple.
I think there's potentially a bit more debate around, say, patellofemoral pain or kneecap pain, sort of a little bit later, 15, 16 year age bracket. I do think there's some importance in managing that well. But your Severs, Osgood-Schlatters, there's, again, realistic amounts of pain, and then there's significant pain, making sure it doesn't escalate. But
So it's trying to keep them in that manageable space.
yeah, low levels.
If it's a bit uncomfortable, we can manage it, you can continue with sport.
Yeah.
You're
Yeah.
not going to be
Hurry up and
one
grow.
short.
Yeah. And you get kids at that point going, oh, okay, how far off are we? Because it's been a 2 or 3 year, and they'll come and go. It comes and goes with the season. It comes and goes with, growth and a cumulative load. I try and explain to kids sometimes that it's like a bucket of water with a hole in the bottom, and you're pouring water in the top. At some point, if you go faster than it's coming out the bottom, it'll overflow, it'll get bad. But if we slow down what we're pouring in, or we stagger it a little bit better, it won't overflow. Or if we have 2 or 3 days off, it'll run down. We're a lot further away from being really annoyed.
Managing the load.
Yeah. Yeah. All right. Still don't know why.
Maybe your clicker just ran out of battery.
Oh, no, it is working. It's just scrolling down. Hang on. Sprains. Did want to talk on sprains as well. Sprains is probably one of my pet hates too, with especially this doesn't fall just into kids. It's so common, so common. Can I get a hands of anyone who's like got bad ankles or It's the most common presentation, most common musculoskeletal presentation to all Western hospitals. It's massive. We roll ankles all the time. You go to hospital takes an x-ray, says no fracture, off you go, wait for it to settle down, we keep going. The ligament at the front of the ankle is the most commonly damaged ligament in the body. It's very frequently damaged. Severe sprains can be a lot more insidious. They damage the cartilage in the ankle joint, and then that seeds sort of long-term change. My view with sprains, if we're having to strap or we're going over on them at all, even once every 6 months or so, we should be doing rehab. That rehab is so incredibly effective. It's amazing how effective it is. It doesn't have to be complex or long-term. Everyone should be familiar with the knee reflex. Is everyone? And look, those of you who've seen me might hear common traits or conversations, so I apologise if I'm repeating myself. But your knee reflex, basically what happens when you hit that tendon with a hammer is your quads stretch slightly, and there's a signal that goes from those muscles to your spine, and it comes back to those muscles to kick out. That's not a thought reflex. It doesn't go anywhere near the brain. It's a reflex. You have the same thing in your leg. So as your ankle goes to roll over, the muscle down the outside here stretches, sends a signal to your spine, goes back, hits fire, straighten up. Once you sprain an ankle once, that signal doesn't trip as early. So that pathway slows down. It doesn't trip here, it trips there, it's too late, we're already over. The part that I find really interesting about it is the way it synapses at the spine and the way it interprets that signal at the spine is that if you damage the right side, it slows down the signal to the left. So having rolled the right ankle puts you at really high risk of rolling the left ankle. If you retrain that pathway, it happens way earlier. The risk of going over is minimal. So I actually think, and we'll go through a bit later, but physio, podiatry doesn't matter. Seek some input, start doing some rehab. And if in that scenario people are going, I just want to give you a brace, or start asking for rehab, like start requesting it, because the research for it is fantastic.
So early interventions are key?
Yeah, absolutely.
Early movement, as long as there's no fracture?
Yeah. Footwear. This is always a controversial one. This is a controversial one for lots of reasons, and I will preface this by saying it's clinically guided, but a lot of this is my opinion. Just because I have one, it doesn't make me right. I don't mind being wrong, and I'm certainly happy to discuss it. But choosing the right footwear, I think, depends a fair bit on age. And I also think there's quite a bit of the dialogue that goes around this stuff is also trying to get people to buy stuff. It's always got a background in trying to make people spend money, and I hate that. It drives me mental. So if we start with toddlers and we start with that age bracket, making sure toddlers spend time. Toddlers, it's actually really important to spend time outside of shoes and in low structure shoes. They need to develop muscles in the foot. They need to develop intrinsic tone. That's really important. They also need to feel different textures and ground surfaces and things like that. So spending time out of shoes is important. Where that advice changes is when you have a deficit or an issue. So if we start seeing an increase in trips or falls or fatigue or an early fatigue point that's beyond normal for that age bracket, that advice might change. But even if I'm asking parents to get their kids to spend time in structured shoes, I'm still in that same consult saying, make sure at home we spend time out of shoes. Changes brain patterning, it changes growth in that tactile space. So that's going to differ very, very greatly from adults. Toddlers are also out of shoes most of the time in fairly protected environments. They don't walk around, the shops. Adolescents, so I've got kids on the cusp of toddlers, toddlers to adolescents and young kids. I don't believe there's always a great need for really structured shoes. I don't always think they're as important as long as they fit well, as long as they're not bunched up in a shoe. I think it's fine to have shoes from Target, Kmart. Yeah. My kids as toddlers, I probably shouldn't say this in a public sphere, but my kids as toddlers, 95% of their shoes are from the op shop or marketplace. Absolutely fine. Absolutely fine. I will probably still, into adolescence, hand-me-downs as often as I can. Again, that advice changes when we start seeing deficits, when there's reasons for it. They're tripping, they're falling, they're fatiguing early, or they have a significant foot shape at either end of the spectrum. So significantly flat or significantly high arch feet. That advice might change, but for the most part, I'm not too stressed until we start, and I go back to what I said with growing pains, until we start avoiding activity or changing our behaviours around activity, or we see a deficit in like trips, falls, fatigue and injuries, then might be worth getting some footwear advice. Before that, don't stress. Nearly all of the advice in that space is targeted at mums, that if you don't do something now, they're going to have problems in later life. And I think that's rubbish. It makes me mad because it's absolutely not true. So adults, this might start to change, especially if we have injuries. Keeping in mind though, with this stuff, that with adult shoes, picking the right shoes, I like analogies, I like stuff to make sense when people leave and they don't have me there. You've got to consider what we're doing in them. So if you're going to go out to dinner, walk 20 steps to the car and back, doesn't matter what you're wearing. You don't have to be good shoes all the time. Again, I shouldn't say this in a public sphere. I still wear Havaianas. What you're doing makes a huge difference. So what you're asking of your body for that day, what you're expecting yourself to do and how much load you're carrying for the day makes a huge difference. When you start doing more and especially throw in injuries and things like that, absolutely shoes become really important. The analogy I like, and I'm gonna single Emma out. I'm going to take you down to the beach and make you walk or run 10Ks down the beach. Yep. Maybe. Are you going to walk near the water or in the sand dunes?
Near the water.
Why?
Because it's not as uneven, then it won't hurt my back as much.
It's easier to walk. It's really, really, really hard to walk in soft sand. It's really fatiguing to walk in soft sand. So we walk in soft sand, your foot moves more, the ground moves more, everything shifts, and you use a heap of musculature to hold yourself stable, to stop your hips from moving and your back from moving. It's fatiguing. It's really tiring. Then why would I walk in Skechers? It's like strapping a sandbag to my foot and expecting myself to walk 10Ks down the beach. So if we're doing significant amounts of load or significant amounts of walking, shoes should be firm. They should be stable. The narrowest part of the shoe shouldn't bend in half and twist. And I think what's also important in that space is selecting shoes based on a feature, not on a brand, I really don't care what brand they are. I wear Brooks because they do a pretty good discount for us, and and the last time I got fitted, I had Brooks, so I just jump on and get the same size and the same shoe. Just because I wear Brooks, it doesn't mean we should go and buy Brooks. Buy what fits your foot with good features. Don't buy a brand. There's nothing that Brooks do that New Balance can't. There's nothing New Balance do that they all buy foam from the same people. They just market it differently. I still think my view on shoes is that they're all based at zero. They're all pitched at 0 degrees. Shoes don't have arch support. They just have marketing departments. You can't pull a liner out of a shoe and actually see contour that controls an arch. They don't need it either. 9 times out of 10, if someone's not pathological, they don't need arch support. What you're buying when you go into a control shoe is stability. So you go into a neutral shoe, generally speaking, they're a bit more flexible. So you're a bit further down the beach. You want a little bit more control. You want to get through the day without fatiguing as much or deload a certain structure. Then going to a control shoe is just buying more stability. It's a stronger sole, a stronger base. Just taking yourself down the beach further. They're still all at 0 degrees. You don't buy a pair of shoes that sits here. They age to that sometimes, but they're not controlling, they're just stable. And some of that advice changes. Hockers are fantastic for forefoot injuries. They're fantastic for deloading certain structures during an injury phase.
Yeah. It's like someone with a bunion that needs like a metal rocker plate in it. So
Yeah.
they can their toes and
Or
things like that.
pain underneath the forefoot, generally, bursts, neuromas, things like that.
Yeah.
I certainly, encourage them in certain conditions, but again, the brand's less important than the features of it.
Yeah.
So Hocker's name sort of was put out there by the Bondi as this big solid rocker sole.
Yeah.
Every other brand does it now. And
Everyone
they all do it. So if you're buying for a feature, fine. Barefoot's an interesting, it's a very controversial topic, and I don't think it's right or wrong. Yeah, fit in here. It's such a controversial space. Again, this is probably my opinion, and I'm just going to delve into it shortly, but most tissues in the body are adaptive if you give them time. So tendons, ligaments, skin, muscle, they all adapt really well. You start lifting weights or doing a fair bit of work, you get callus on your skin. Bone behaves the same. You start doing more with higher impacts and higher loads, your bone adapts. You go through 12 entire sets of bones in your life. Every cell there will get annihilated and rebuilt 12 times in your life. So if you transition to something like barefoot runners in enough time to allow that bone density to increase, absolutely. If that's a long-term goal and we're 50 and we want to wear barefoot runners, great, but give yourself 5 years to get into them. Yeah, and that's, I think that's reasonable. Where I would argue against it is then if we have an injury and that is then impeding us from deloading it and getting it better, then I'd argue against it. But as a lifestyle, it's fine, it's awesome. In fact, your muscle strength and intrinsic tone is going to be awesome. So fit's important, the way it fits on our foot. Features, not brands. Shoes aren't arch support. What are you doing in them? And are we in pain? Because if we're in pain, then we need to start considering more structure or, what are we doing to treat an injury? How long do we need to be in the right shoes for? Is also important. If you've got a load-based injury and we're talking about deloading it for 60% of the week while you're at work, the rest of the week might be fine. Don't have to wear perfect shoes all the time. I think that bothers me.
What do you think about like those foot scans and stuff and the experts?
Yeah,
athletes?
that's a great question.
Because some of them are 12 and I'm not.
Exactly right.
And others.
Athletes for people.
Yeah.
Yeah.
It's
I find that really interesting.
I-
They get out their little iPad and like, what are you doing?
I've got a theory that yeah,
Assume it's financial based.
pretty much, yeah. Again, this is my opinion, because I have it doesn't make me right, but we know psychologically that if somebody's given too many choices, they will make none. So you walk into a shop and there's 500 shoes on a shelf, the chance of you walking out purchasing something is almost zero. Once we go past 3 or 4 options, we can't effectively weigh up pros and cons. So from a psychology and sales perspective, they know that well. They know that really well. So you walk into Athlete's Foot, it's overwhelming. You walk across that thing and they will always do one thing. They will always go to the iPad and then go out the back, and they come back with 2 or 3 boxes maximum. So they've checked what they've got in stock in your size that roughly fits that foot shape, and they come out and put it in front of you. And physiologically, your brain then goes, okay, well, I like that colour, but I like that fit, and I like that price tag, but I can weigh them up.
To give you a multiple price point option also.
Yep. So there's a lot of like focus groups and study and research that goes into that sales point. Walking over I've watched people walk over that thing. Oh, I've watched people walk over it with. I saw somebody one day who had such a high arch foot that I would start to question neurological disorders. And they went, oh yeah, your foot flattens out quite a bit. And I'm going, does it? Am I looking at this? Like, it's in saying that, they then at least have some basic fit knowledge. So they at least go through some training. They're still in retail, in shoes. And like you say, most of them at 14, 15. I think Athlete's Foot does a reasonable job at trying to train people or bring them up to a reasonable standard. But as is the same with any of that space, you've got to be skeptical and you've got to be able to make the choice or like look at it and make an informed choice yourself. I think that's really important. And that's where like features and picking it up and going through it and understanding what you're looking for is really important. So these are probably the 2 most common ones we see with adults. So plantar fascial pain and Achilles tendinopathy. Show of hands who thinks they've had one of these or who's had one of these. Really common. Really common. Probably 40% of people, 40% of the adult population will have some version of plantar heel pain. So talk about plantar heel pain is plantar is a direction. It just means the bottom side of the foot. This has somewhat been renamed in podiatry circles as plantar heel pain. And there's a really good reason for it. Remember me saying before with Severs that some people get treated with orthotics and it works and some it doesn't? How many treatments are there for plantar fasciopathy? You start reading it, there's hundreds. Half of them are rubbish, but it's such an extensive list because that's a blanket term that covers about 15 different pathologies. That covers a lot of different things. So if you've got 10 or 15 different diseases, you've got 10 or 15 different treatments for that. It can be, for you then as a, trying to find somebody to help you, it can be really, really hard to pinpoint who's going to help me because they've got to work out what condition it is first. So just to illustrate the point, and I totally appreciate we're not going to get all of it, but who knows what a bursa is? Yep. Fluid-filled area. You can have bursitis under the heel. you can have edema or dysfunction of the fat tissue underneath the heel. They cause pain directly under the bottom of the heel. It's not plantar fasciopathy. So again, plantar is a direction, it just means the bottom of the foot. Fascia is a type of structure. It's this white ligamentous band that runs along the bottom. If that's irritated, that's plantar fasciopathy or plantar fascial enthesopathy. Bursa, fat pad impingement. You can have what's called Baxter's nerve impingement. So you get really, really, really significant radiating pain around the heel. And it presents kind of like really deep bone pain or fracture pain. That's because the nerve that supplies that bone is being pinched and we get a really severe heel pain. That pain, that Baxter's nerve entrapment, can be induced by muscle spasm of the muscle that sits on the side of the foot, the myos, abductor hallucis. If abductor hallucis is in spasm, we can have symptoms like plantar fasciopathy, but way more severe. Those people may have been in pain for 6, 12 months, and you do a session of dry needling and it fixes them. Because you reduce that muscle spasm that's causing the nerve impingement. Again, not plantar fasciopathy. So there's a lot of nuance when it comes to this. I've had in the last couple of years, 2 blokes come in and say, probably in their 60s, I've had plantar fasciitis for 10 years. And I've started talking through it. And I did this to someone this week and regretted it. And they told me what they had and went, okay, you've told me you've got plantar fasciopathy. I'm going to spend the first 10 minutes trying to prove you wrong. And these 2 blokes were absolutely wrong. Had blood clots, or not clots, had blockages in their proximal arteries. And they were getting what's called claudication pain. So the muscles in their feet didn't have enough blood supply for them to function. So as soon as they started walking and moving, they start getting pain in their arches and they go, oh, I've got plantar fasciopathy because it's pain on the bottom of my feet. I guess the point I'm trying to make here is that there's a lot of nuance in that. Making sure somebody actually takes the time to sit back and go through history and go through what's going on. And then also understanding, like, if you're not improving or we're not getting somewhere, do we go back to that point of diagnosis and start building from there? So it's not an easy one, and that's why there's so much variance in how it presents and how it treats. I genuinely think 70% of the people who turn up and say, I've got plantar fasciopathy, don't. Which is awesome in some cases because they're really easy to settle. Sometimes it's not. That's also the most infuriating thing about it because we start treating it and we've all got friends who've had it, we know someone who's had it, and you have somebody who's had 2 years of pain and somebody else goes, oh, I just stretched for a week and it went away, or I rolled on an ice water bottle and it went away. You're like, thanks, that's not helping me. It's horrible. I've given myself this in some form, using an acupuncture needle, gone in and pinched it, poked at the bone to try and elicit the same pain, and had it for like 5 days. I hated it. At like 5 days, I'm taping my foot up to go, I don't want this anymore. And we see people who've had it for a couple of years. It's horrific. The same applies with Achilles. So a lot of Achilles tendinopathies aren't Achilles tendinopathies, or you've got totally different conditions when it presents at the insertion versus mid-portion. Then you can have a bursa form in the space behind the Achilles, so sitting in here. Then you can have another bursa that forms on the outside here. Gout can present in an Achilles tendon. So you can have really severe episodic pain without something that brings it on. It can be gout. Now, gout typically affects a joint, nearly always, but you can see it in an Achilles and so very rarely in a fascia. So highlighting that what works for one doesn't always work for the next is somewhat important.
Do you needle the actual Achilles tendon?
Not the tendon itself.
Because we learned it in our class, but then 5 minutes later got told not to do it. But I got to say, someone needled mine while we were learning it, and I never got pain. So my brain kind of goes towards it, but obviously the research sort of says don't put holes in tendons, but then went to something that said needle the elbow tendons, and now I'm not sure.
Tendons are a world of their own. Yeah. There's, in theory, you can go back to first principles and go, I mean, half of the treatment we use for tendons now is creating a new injury. You know, shockwave is trying to create or elicit an injury. So you can argue that, yeah, tendon, if you create an injury, we get healing, provided it's past a certain point of the acute phase, that it might re-engage a healing response. But then I'd almost argue that some of those are a slightly different pathology or a slightly different case. And that's where, so I've got the ultrasound here, just out of interest. If anyone wants to have a look later, like have a look at the tendon and have a look what one looks like. Sometimes you'll have on ultrasound this really thin line. You'll have this really, really, really thin layer of fluid around the tendon, and it's the peritendon tissue, gets swollen. Arguably you damage that or perforate that or create a response, then an Achilles tendon pain that's actually from the peritendon might settle. But it's, yeah. Yeah, it depends on the cause, and that's the really tricky part about these things.
Is it like, so if someone came to see you and they're an adult
Yep.
with what they thought was plantar fasciitis, which is what we see a lot here, what we send up to you a lot.
Yep.
Would you then just go straight to using your ultrasound, looking at the structures, the burst of the Achilles, the plantar fascia itself, and just
Try not to.
Right.
And it probably an insight into my mind you don't want, but the ultrasound is so good with some of those things that I actually have to tell myself to stop using it, because we had really good assessment tools beforehand. Trying to then use that to collate what I thought and check on what I thought. So trying to come up with a diagnosis beforehand and then actually go back and check with myself. I want to prove myself wrong, because the first thing that I think is going on is not always the case.
It's always multiple things. It's never one thing.
Plantar fascia is exactly that. You tend to have multiple things at once. And a classic is someone who has typical plantar fasciopathy, and it is typical tendon degradation, but then they get secondary muscular spasm. So your brain's trying to protect it, so it's doing this. We get muscle tension in the calf, in the foot, and then you start seeing some of the nerve symptoms into the bottom of the foot because of the muscle spasm and because of the high tone in those muscles. So you add in a second condition. And that's, I often go through with patients, especially for like Achilles, should we be using, ride it out? Should we be using myo, massage, those sorts of things? Absolutely. If you think it's an adjunct to what we're doing and you can use it alongside what we're doing, absolutely. Because if it helps settle that muscle spasm and lets you engage in the rehab properly, awesome. It's fantastic. But then understanding, like, if we've got a primary deficit in strength, that we're making sure we're addressing the strength deficit at the same time. So understanding strength in these conditions, I've put down the bottom there. The biggest predictor of most foot pains, the single biggest predictor of most foot pains is lower limb strength. Calf, glute, quad, hammy, calf, intrinsic muscle strength, the biggest predictor for all of those conditions. I saw some research maybe 12 months ago on calf circumference as an indicator of lifespan, as a predictor of lifespan. It was really cool. And there was some research that came out in the last week that was thigh circumference as a predictor of lifespan. And even when you take out other factors like body mass, fat mass, things like that, it was still a predictor of lifespan.
So the bigger the circumference, the longer you live.
Yep. Yeah. There's a sweet spot, but calf was under a certain amount. Below that, life expectancy was like 10 years. And it fell off a cliff. The overall indicator is activity. But the single biggest risk factor, when I say risk factor, it's what are the things that you can engage in that reduce your risk more than anything is strength training. So Achilles, plantar fascial, tib post tendinopathy, progressive flat foot deformity, all of these really significant long-term issues with feet, strength is a huge role, plays a huge role. I don't think I can understate that. Problem is, once an injury occurs, or once we're at pain, you actually need to settle pain before you can build strength. If you've got the strength there to start with, it's far less likely to happen. Has anyone got questions on this stuff before I? Orthotics? Yeah. Are orthotics helpful? Sorry, I didn't actually. In terms of plantar fascial pain, yes, unequivocally, absolutely, I agree with the use of orthotics in some or most cases. It doesn't, if you're talking about actual plantar fascial pain, plantar fasciopathy, and targeting that one condition, it doesn't have as good research as some things. It's got really good research. To be honest, Shockwave has better research than most.
Do you do that?
Yeah. Orthotics depends on what. So if you're using orthotics to try and address sort of, generalized overload and a multitude of, pain patterns, absolutely. And I differ depending on the person quite a lot, but let's say somebody turns up with plantar fascial pain and says to me, I've got heel pain, it turned up in the last 2 months, just on my right, I've never had it before, I pull out the ultrasound, right looks ordinary, left looks fine, the Achilles look fine. I'm going to start treating that as an injury, not a problem. They don't have a problem, they've got an injury. And this is where I think podiatry gets it wrong quite often. They see an injury and go, I want to give them orthotics. Usually comes from a financial standpoint more than anything. If that same person comes in and says, I've got pain in this heel and 6 months ago it was in this one, and 2 years ago I think I had a cortisone in one of them, and I had a cortisone in another one, and they've got this sort of history going back a fair way in terms of heel pain and recurrent patterns, or a multitude of foot issues, I'm probably going to start looking at orthotics earlier to try and address the load on that tissue and then deal with other things adjacent to it. So it's really nuanced, and I think if anyone's recommending you orthotics, make them justify why. Make them tell you why. And if their ruling is you've got flat feet, walk out the door. As far as Achilles goes, I don't think it's particularly useful. I put that a long way down my list on Achilles. I don't think using orthotics for Achilles is particularly useful. Again, I work with practitioners who would differ on that, and their clinical experience would be correct as well. But there's way better starting points, and there's way bigger benefits to be had from cheaper and less invasive options, I think. Yeah. Any other questions on? Cool. Where do I go for help? Again, this is always going to be a very controversial one. Physio versus podiatry. Either, I don't care. I really, as long as you think you're getting good advice, as long as you trust the person who's looking after you and they've spent the time with you to go through what's going on and actually look like they're trying to understand it, I don't care. My general rule of thumb, if we're talking, say, ankle sprains, if it's acute, it happened yesterday, and we're really worried about, significant, should we be going to see a surgeon or something like that, physio. Acute injury, 9 times out of 10, physio are better trained at that stuff than podiatry. I'm speaking very generally. My view then changes when you start going into recurrent long-term chronic patterns that aren't settling in the normal ways or the normal things that you'd expect. Podiatry, I think, plays a different role. But I want to challenge the view of one or the other. And this isn't just physiopodiatry, this is healthcare in general. How many cases have you seen in adjunct with myo and they get a better outcome way earlier? We're all trying to achieve the same thing. We're all on the same track. Unless something is fundamentally in opposition to what they're doing, we should be working together. So if you're seeing podiatry and physio and they're not talking, tell them to pick up the phone to each other. If they're not happy to do that for you, yeah, tell them to find time, because healthcare works a hell of a lot better when people speak. A hell of a lot better. I had a patient in the room the other day, and unfortunately this doesn't happen that often, but I had a patient in the room who had a serious issue. I walked out of the room with my mobile and I called her oncologist and her GP. And within an hour, she had to hang around for a while, we had a really, really, really good outcome, and we had a lot of stuff done and achieved within an hour. Because they picked up the phone, everyone left their egos behind, and everyone talked to try and get what's best for the patient. So I think if anyone's really trying to tell you the other person's wrong or vice versa, make them explain why if it doesn't make sense. Make them talk to each other. We all get better outcomes when communication happens.
Look at the client I sent to you. I was treating her like she really hurt her back, and then she just needed to listen.
Yeah.
Getting bogged down in the details. But
It's
she
so
was
easy to
kind of
do.
on the top of her foot.
Yeah.
I had no idea that was a really good option that she might have been doing.
And sometimes we go way too in depth, and I've got the ultrasound out and then go, oh, hang on, it is just lacing. It's cutting off blood supply. The other part to that, and I think this includes me, it should include me, if you start seeking care and you get to a point where you think you should be seeing results, or you've been led to believe that you should be seeing results and you're not, ask the question. Because some of this stuff is really, really, really frustrating to treat because it does modify and change, and should have a good explanation for it. But if you get to 6 weeks, 12 weeks and aren't seeing change, reassess what's going on. I saw a patient the other day from the UK. So her and her husband visits me while he's here in the country every year. And she came over and she goes, I've been seeing a physio for my foot problem. And we talked through for how long. She'd been seen for 12 months, doing the same exercise for 12 months, and it hadn't changed. And my first thought was, okay, and have you asked why that hasn't changed? I asked her about what exercise she was doing. I started looking at her foot and I was like, well, geez, I think the physio's on the right track. Like I think you've got the right exercises, and I'm still trying to piece everything together. pull out the ultrasound because I thought it was a tendon injury or a tendon problem. It's got a really thick part on the top of the... Pull out the ultrasound. Tendon was fine. Underlying joint was absolutely annihilated. She had the most severe single joint arthritis that I've seen for a long time. If I didn't have the ultrasound, I probably would have started treating her for that tendon injury, and then at 2 months, when she wasn't responding, gone, what's going on? But she was at 12 months of not responding and wasn't asking what's going on. So if you get somewhere down that track of treatment and we're not seeing change or we're not seeing a response, ask the question. It's not unreasonable. I really don't care if somebody gets a second opinion when they're seeing me. I mean, none of us should take offence. If our priority is your healthcare, no one should be taking offence. NHS. NHS, UK, I think, yeah. And maybe the other point to that is maybe she hadn't verbalised properly at the other end. I don't think I'm getting better. Like, she was someone that could probably be a bit guided by suggestive language a bit. But it's pretty poor. But that model happens everywhere here. That model happens, you know, in Australian healthcare settings all the time. I really wish it didn't, but it does. I think one of the red flags in that too is the retail on sale. It's, for me, a red flag in podiatry when you walk into the clinic and there's a shoe rack and then there's some other retail, half a dozen retail items, and every patient comes out the front and they've got a spiky ball and a TheraBand and a pair of shoes and a compression socket. Like those things have their place, absolutely. But if it's being hounded, you're going to a therapist who's also a retailer. You look out here, there's functional stuff like socks. That's it. Like it's.
We used to do all stuff. It's a non-event now. We just try to fix bodies.
Yeah, and but it's also in the delivery as well. So if you're leaving somewhere all the time and it's you need this and you need this, you're making a fair bit out of retail. There's actually a point going back a few years where one particular state in Australia, quite a few of the private health providers were removing podiatrists from their list of practitioners and reclassifying them as retailers because they're in shopping centres with a shoe shop out the front and every treatment plan just revolved around selling shoes and out you go. Yeah. Talking to the people you trust too. So talking to SMAPS, getting guidance from other people, getting guidance from health practitioners that you trust can be pretty helpful. Use them. Yeah. Busting some myths. These are the things that I hate in podiatry. These are the ones that come in the room and I go, oh, geez, okay. I have to bite my tongue a little bit. Some of these we've covered. Shoes cause bunions, we haven't covered. Who's ever heard shoes cause bunions, or what your mum put you in as a kid caused bunions, or, yeah? High heels, yeah. There's very, 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 very limited evidence to support it. Very. Who's ever seen a retail item like a brace or something for a bunion? Been advertised, you know, retail like corrective braces and things like that. Bunions are here, right, on a foot. Bunions happen here. Would be the most common. They don't. Bunions come from here. Bunions, the overwhelming evidence is that bunions come from here. They're a genetic narrowing of this side of this joint, the inside of the joint, that causes the metatarsal to shift and then the toe comes second. So the shape of that joint isn't caused by high heels. The overwhelming majority of those cases are genetic. It's inbuilt, is what it is. So don't believe everything when it comes to bunions. Shoes have arch support, we've covered, they don't. They're just more stable. Some are more stable, some are less. Common injuries have a common treatment. Shockwave fixes plantar fascial pain, or exercises fix Achilles, or they don't because they're not always the same condition. I think that's really, really important. Flat feet need orthotics. They don't. Unless there's some of those traits that we had before, like repeat injuries, avoidance of activity, inability to cope with normal load or normal loading patterns, absolutely. But kids with flat feet, the number of times I see mum come in because somebody said, and I've seen it, the maternal health nurse has said, your child's got flat feet, off you go and see a podiatrist. Until the age of 3, toddlers actually have a fat deposit in the arch of the foot.
That's what they sound like little elephants.
Yeah. And that fat deposit dissipates around the age of 3. So before that, every toddler's got flat feet. They don't, they just have a bit of fat contacting the ground there. It can predispose to some injuries, but it's not a problem. Flat feet aren't an issue, they're not a pathology. I think where some of that comes from is they can be a visual indicator of some bigger underlying problems, but we're talking about severe flat feet. So you go back to World War I and II, people were excluded from the military for having really flat feet. I think you'll find, so you heard me say before, the neurological high arch foot. There's a particular foot shape that can look like you only see in neurological conditions. There's also a particular foot shape you only see in sort of congenital, genetic or gene mutation type conditions, and it's really flat. I think it was just used as a visual screening aid. They go, well, flat feet, out you go. And we've held on to this demonised idea of flat feet as a result. I don't buy it, I don't like it. They're normal. Having flat feet allows us, or having feet that flatten a little bit allows us to adapt to different ground levels and walk on different terrains. It also allows us to run and absorb some shock. It's a good thing.
Don't you feel that that affects the knee though?
Yes, in some people. So subtalar joint range, some people, the axis of the subtalar joint can deviate quite a bit, but in some people with flat feet, the leg tends to internally rotate a lot as they come down. That's where I think it has a massive impact on hip, knee function. Some people you get don't have a lot of, they can be really flat, but the knee and the leg doesn't really bend or twist. It doesn't internally rotate when they weight bear. I don't think orthotics do a lot in those cases because you're not derotating the leg, you're just changing the foot position. So yes, it absolutely, in the people that it drags the leg.
And what about over time in the big toe joint?
In regards to what? Yeah, it adds compression to the joint, and it can predispose to things like plantar fascial pain. The joint, I don't think it's necessarily going to cause it. It can accentuate it if there's already like a deficit, a chondral deficit or a defect in the bone or an injury to the joint. But cartilage is pretty good at dealing with compressive force. Bone's pretty good at dealing with it. Unless it malaligns the toe. There's a lot of nuance in that question though. There's a lot of traps and a lot of, yeah.
I think orthotics are actually really good. I just think in particular people, very beneficial to set up a good structure
Yeah.
help in supporting joints, not so much the actual foot, but
I still use them a lot, and I know I've sort of probably come across like I don't use them at all. I still use them a lot, but I think I,
minute are always relevant.
yeah, and I think I really hate the view of podiatry that you just go and get orthotics. So I probably actively push back against that a bit more. I just want people to justify why. I want people to think about why a bit more.
The difference between orthotics off the shelf and made.
Yeah. There's a huge difference in what they are and what they do. In some people, in some cases where you've got a smallish injury with a small reason why it's turned up, off-the-shelf help really well. I would use more off-the-shelf orthotics than customs, especially if you're treating short-term injury, not long-term deficit. Customs, you can't achieve the same level of control in an off-the-shelf as you can with a custom anywhere near. They're not as firm, you can't put control in the right places. And one of the problems with orthotics is you can change where you put control and how much, and that affects how much force goes through the orthotic, how much you feel the orthotic. If I make an orthotic script wrong, it's uncomfortable, regardless of who you put it under. Like they are horrible. If you make a custom orthotic wrong, they can be absolutely debilitating. The problem is most podiatrists pay so much to get them made, they won't then take them out and remake them. They just go, oh, well, sorry, there you go. I generally get them remade. It's been a long time since I've remade one. But you can't control anywhere near the same amount of force as you can in an off-the-shelf, with a custom. Questions?
Thank you very much,
That's
Ed,
all
for
right.
coming today. I think it was really good and really informative for all of us. Does anyone have any questions? I'm just going to put this little black box near you, though, when you just ask them. Go.
I have a question about avulsions.
Yep.
What would be a good course of treatment, or what would you recommend someone who has an avulsion do?
Oh,
It's not me, it's my husband, Shay. My husband's foot injuries. He's got a horrible body, but he now has an avulsion. So,
is it acute, like recent?
7 weeks ago.
Yeah, okay.
So
I'm
a
telling you.
fracture, an avulsion fracture.
No, it's not a fracture.
Right.
It's the muscle, apparently.
Oh,
Yeah, muscle
Right.
pulling on the tendon, something along those lines.
So my knowledge
a
of an
fusion?
Oh, maybe I said the wrong word. Hang on.
Yeah, Google it.
No, he wrote it to me in a
I wrote
message.
Has he had scans?
Yes.
Yeah, okay.
Yeah. No, that's avulsion, is it?
Yeah, so an avulsion
Yeah.
is where the ligament
Yeah.
pulls a little pebble of bone off with it.
Oh, okay.
Yeah.
There you go.
So it's like
So it's
we
a
call
fracture.
It an avulsion fracture.
right. Well, there you go. Yeah. Is there anything like he already has orthotics? Is there anything he can do to help?
We need him to be able to run again so I can have a break from being a footy trainer.
You're
Is it
doing
the outside of
free
the
train with me. You're doing it in your team.
Outside of the foot?
Outside, yeah.
Yeah. And it's fairly hard without seeing the images and seeing the foot. And again, I don't want to give too much like personalised, right? But yeah, bracing it, deloading the tendons as much as you can, strapping it as much as you can. Most of the perineal or the perineal or fifth met avulsions, most of those, if they don't heal back to the bone, most of them are still stable with inside the tendon.
Yeah.
So we think about a bone fragment as just like pulling off and floating away.
Yeah.
It's still within ligament, it's still within the tendon. So at some point that will callus and stay there. You find them quite often on imaging down the track as an incidental.
Right.
I'd probably look at the type of pain that he was having, whether it fit with bone injury still or whether it fit more with tendon load and tendon injury, and then start treating one or the other. Because it may very well be perineal. Like if he's done an avulsion, it might be a tendon, small tendon tear with it as well.
Should I send him your way?
Yes.
Yeah?
Yeah, do that. Do that.
Again,
it's really, if
or-
you stay back
or
later, you can
physio.
see his-
He has been seeing physio.
Yeah.
But we just thought maybe, you know.
So do you know what I say to people? And this is probably why I spruik up lots of business for Ed. It's if you're a physiotherapist, you go to university for 4 years and then you do your grad year. And that's the whole body. And then if you go to become a podiatrist, you go to university and you just do from the knee down for 4 years. So I do think that they have, like you said, I like the care team, you know, and I think it is. But I feel like if you're not getting anywhere or he feels like he hasn't had a good explanation or he's not sure.
Yeah. I just feel like 7 weeks is a long. And originally
7 weeks is a really
long, so that
7 weeks
my
is a long
question.
time. Yeah, I think that. Feel free to pop in around sport when I'm around. I'll help you tape it up or give you some techniques to do it. But yeah, go and see Ed. He's just in Somerville. I would. That's where I'd be sending my husband because I can't deal with the whinging.
That's exactly where I'm at.
I was like, shush.
I'm like, can we do this yet?
No more football
I
for
have to go get the
you. Yeah.
It's actually there's actually some really good clinical data on us living longer with a spouse. Don't tell them that.
Every
But
second
my-
bloke you get in is, I can hear my wife.
My wife sent me. My wife made me come. I don't know.
Yes, your wife is
Yeah.
Does anyone else have any questions? You've got Ed here. Yep. Yes.
Thanks. With severs,
Yeah.
can it get to a stage where the pain is that severe that waking up in the morning, you can't walk,
Yeah.
you can't wait there? It can get,
Yeah, absolutely.
yeah.
So while we're in a boot?
Yeah. So
I've had to put people in a boot for severs
For
before.
severs, yeah.
Absolutely. It can be debilitating.
Yep.
And trying to empty that bucket. Once it gets to that point,
yeah.
He doesn't have enough button.
trying to empty that bucket's really, really hard.
Yeah.
It can get really, really bad.
Okay.
And
That's what we should do the ultrasound on.
Oh, yeah.
yeah, if you want to have a look at a growth plate, yeah.
You want to come up?
Just as like a concept or an idea, you're not going to see much other than sort of the growth plate itself, but
I'll take this off. Thank you. You can have this, buddy, in case he asks you a question.
All right.
There you go. There we go. And do you want me to hold up the picture?
yeah, go for it. But yeah, if I'd still be, you still be going through all of your sort of
we saw a physio,
yep.
and he said, like, you know,
This is fun.
days off during the week, keep playing. You can't
I'd
do
be at
any
home
damage.
with ultrasound and stuff.
Me too.
It's been 11 weeks.
Yeah, but
In a
then I'll
boot?
be like,
No.
chat GPT
Just a
to
week.
see if I'm
But
dying because I found something.
Yeah, and
3 weeks, you can't wait there. But we're waiting on the result for an MRI now, so.
yeah, okay. And look, MRI will be really good. Have we got? I'll need to see a little bit. So turn the gain up a little bit.
This is like, I feel like as a myo and been doing it for such a long time, I'm okay on MRIs and X-rays, ultrasounds. I'm like, dude.
So this is the heel bone. You can hold it up there if you
I can
want.
hold it up?
You got the heel bone sitting at the top and the plantar fascia coming over the top. And then can you see where the heel bone stops and starts again here? So that's the growth plate. So if you unfree.
Massive space because he's growing.
So they're actually still two totally separate bones. And then if you come back up around the Achilles side, again,
Wow.
so you can see the Achilles tendon up here at the top. Underneath that's the fat tissue. And then coming further down, you get the heel bone.
And a space.
Actually looks, yeah, how old are you?
11, almost 12.
So you can still see the growth plate there.
Like outside foot pain.
So you like get up in the morning, bud, and you can't even walk.
No.
What do you do? What are all your sports? What are you, like a footballer, a cricketer, a basketballer? Do all the things?
All the above.
He's getting quite a bit of pain in the outside of his
Yeah.
foot.
Have
I'm
you
getting
treated?
pain down there.
No, I'm triggered, Sonny.
Okay.
It's down, like,
He's shit scared of me.
If it comes to it, I'm nicer than her.
Yeah.
too mean. But like, we've got lots
When's
of
he having
therapists
the
here. We
MRI
could put
done?
you with a nicer therapist.
When's he having the MRI done?
When did he?
see
Saturday.
her.
Waiting on the results.
Oh, it's had it done.
It's had it done. Because we had a feeling, well, we went away for 3 months and he walked.
Be brave.
Had
We had a
a,
feeling he might have a stress fracture.
But you had an X-ray though.
We did,
waited
but
for
they
Had it.
said
Stress
won't come
fracture's
up.
not awesome.
Won't come
I might come back to that a bit later, if that's all right. When,
Yeah, sure.
I'm
Yeah.
going to give you his business card. It's just in Somerville. Okay?
we're just going to grab some.
They had someone else they were referred to, and I'm like, no.
Like straight up though, like just before any of that,
Side
even
of my
before an
foot
X-ray
started
comes
to
back,
hurt.
if you just treat his calves
When he
nicely.
pushed on it.
yeah, when he pushed on that.
I am capable. I think we'll have a family. It's just not my
I'm
preference.
stealing some of
It's
you.
fine. It's fine.
Yeah, but it's, I mean, asking the right questions.
Yeah. I'm out.
What else are we going to ultrasound?
I just find this stuff really cool. I find it so cool
It is
Thank
cool.
that you can
have another
actually,
big foot to compare to?
or if someone wants to have a look at a foot or
They will know.
an Achilles,
They will know. We'll just tickle.
Do you want to do your Achilles, Netta? Come on.
yeah.
Come on. She's got a sore Achilles, so it's a good one to do.
This
This is Netta,
Now-
older Netta. This is my middle son's girlfriend.
So this is still like a fairly basic machine. This is, you go into radiology, it's like 15
That's fine.
times
We
a
don't even
day.
have to like do. We can do baby scans and everything.
I've got,
Do you want to throw Melly?
my wife won't
yeah,
let me
yeah,
take
we
this
can do
home
it
when
as
she's
well.
pregnant
That'll be a good one.
at all. She's like, absolutely not. You're not coming near me with it. I've got a video sat on my couch at home with this at the other end between my ribs watching my heart valve.
That's what I would do.
It is, it's so cool. Like you go a couple of generations back and you couldn't even find out, like, this stuff just didn't exist.
Stop.
It's so cool.
Oh,
What do I do? Touch the thing?
no, I've got to turn it on
Oh,
here.
yeah, turn it on. That's a good start.
Turned it off. But again, it's not like this thing's only to help guide decisions. They're not perfect, but they give you an insight. Like I said before, that lady's foot who I thought it was just straight up tendon injury and looked in this and went, oh, hang on, I'm well off.
You can just hold that just in case you answer something. You've got a oh, there we go. We're on. We're joining your Achilles. Sorry.
Hopefully it doesn't need joining.
Sorry.
It should come up. Oh, what have you done?
I held it. Okay. Can everyone see?
You can see the heel bone down the bottom
No growth plates.
and the Achilles at the top. So you can see that Achilles has got pretty nice structure. It goes parallel basically the whole way up. Doesn't mean there's no injury or tear. There's a little bit of thickening in the middle.
Okay. All right, everyone. Thank you so much for coming. Sorry it ran a little bit later than it was supposed to. Once Ed's packed up his iPad, technologically, I think is maybe like a little bit tricky, but as far as feet is concerned, he's definitely got it covered. Haven't you? But yeah, just like a big thanks from SMAPS and a big thanks
not a
for coming
problem.
here. We really appreciate your time, especially on a Friday night. And it was really informative, and I'm sure that there's anyone that wants to stay back and ask any questions, maybe if it might be more personal or maybe it has something that's a bit more in depth. Ed's going to hang around and we will be here while we slowly pack ourselves up. So a little clap for Ed for coming.
Thanks everyone for coming. Yeah. Thank you.
Everyone enjoy your weekend. Don't get hurt at football.
Yeah, have you got your MRI? Oh, I just want to ask if we can.
You've had MRI done?